Hi everyone, and welcome to tonight's webinar. My name is Conrad Stradum, and I'm standing in for Renee Bosman of Specialist Forum tonight. This webinar tonight is sponsored by Eli Lilly. Tonight we are joined by the esteemed Dr. Prof Fiad, consultant endocrinologist and head of the Diabetes Center in Sheikh Khalifa Medical City in the United Arab Emirates, and our very own Prof Ngoba Tabetse, who I'm sure needs no introduction. For those of you who don't know him, Prof Tabetse is the head of the Division of Cardiology at Wits University. But before we get to the exciting part of tonight's program, just a few household rules. This webinar is intended for South African-based medical doctors only, so only GPs and specialists. If you consent to the sponsor using your name for their attendance register, please type Y in the chat section. I will also post that again in the chat. If you lose connection, just click on the reconnect button at the top of your screen or use the original link sent to you previously to connect. If there are some technical issues from our side, we will be moved to a new site automatically. This should take no more than 20 seconds. All you have to do is wait for the new room to become live. If you have any questions, please type them in our Q&A section. After each session, the speaker will take time to interact with you. Off-label questions cannot be answered due to the HPCSA CPD guidelines. This webinar is accredited for 1 CPD point. To earn your point, you will have to attend the full webinar. Our system automatically tracks how long you spend in the webinar. Please note, as per the updated communication received from the HPCSA CPD department, that we will no longer be issuing certificates for any healthcare professional affiliated to the HPCSA. We supply the HPCSA with a monthly report of the successful CPD activities, and then they will update your profile on their own CPD portal. So before giving over to Dr. Fiad, just a few questions, comments about tonight's presentations. Prof Fiad will give you a detailed review of the cardiovascular risk in diabetic versus non-diabetic patients, and will share some insights about the various categories of cardiovascular risk. And then Prof Tabetse will focus on navigating cardiovascular disease in diabetes. In his presentation, he will look at the pathophysiology of type 2 diabetes and the link to cardiovascular disease, risks, and complications. And with that, I'd like to hand over to Prof Fiad.
Conrad, I think I start first, and then Prof Fiad. Yes, that's correct.
Right. And over to Prof Tabetse.
Okay, great. All right. Good evening, ladies and gentlemen, and thank you again for attending this webinar and sponsored by Eli Lilly. Thank you to New Media and Medical Chronicle for hosting us. And we hope tonight we can discuss this ever-growing burden of cardiovascular disease and diabetes. And thank you again, Conrad, for that eloquent introduction. These are my disclosure slide. And to kick off this evening and really set the scene, what I'd like to highlight, first of all, is that the prevalence of type 2 diabetes is increasing globally. This is something we're all aware of. In 2017, reported approximately 500 million people living with diabetes, and this is estimated to increase to about 750 million by 2045. And one of the main elements that we are aware of is that in patients who are diabetic, one of the huge morbidity and mortality really arises from cardiovascular disease. And this is an important distinction for us to make in determining how best to treat these patients, whom we've traditionally seen as just having a glucose problem. But when we look closely, we appreciate that they are prone to early onset death driven by atherosclerotic cardiovascular disease. Briefly, just as a quick overview, we're aware that type 2 diabetes, as termed the ominous octet, is marred by a myriad of abnormalities, physiological and pathophysiological abnormalities, such as a decrease in insulin secretion from the pancreatic beta cells, increased hepatic glucose production, increased lipolysis, and ultimately leading to impaired appetite and regulation. On the other side, we also see increased glucagon secretion by the islet alpha cells, decreased incretin effect that we note, as well as an increased glucose reabsorption with decreased glucose uptake at the musculoskeletal levels. All of these are some of the pathophysiological anomalies that we note and identify in patients with type 2 diabetes. But over and above this, as much as we have for a long time focused on this glucose-centric approach to management of type 2 diabetes, we've now appreciated that these patients, before they're even diagnosed diabetic, they generally have many other risk factors that sets them up or predisposes them to type 2 diabetes. Typically, collectively, these are called metabolic syndrome or phenotype. So these individuals are generally overweight, they have central obesity, they have hypertension, dyslipidemia, an increased waist circumference, etc. And also over time, from being glucose intolerant, they eventually become fully type 2 diabetic. And when we track these individuals, what we have learned is that each of these risk factors are both individually and collectively significant risk factors for atherosclerotic cardiovascular disease. And what happens over time is that when these patients have lived with these risk factors, and especially once diabetes has been diagnosed by 8 to 10 years, they reach a state what we call a coronary heart disease equivalence risk or equivalence threshold. And this means that they are having the perfect environment for them to ultimately manifest with an atherosclerotic cardiovascular disease, either a stroke, myocardial infarction, or even peripheral vascular disease. And these are typically what we note, or what we call the macrovascular diseases. Now, if you consider patients in your consulting room with type 2 diabetes, it's also important for us to appreciate that a majority of these patients, by the time they have been diagnosed with type 2 diabetes, have not yet complicated with an atherosclerotic cardiovascular disease. And a third of them have succumbed, unfortunately, to this event. I did highlight previously in the previous slide that it takes about 8 to 10 years before these individuals reach an atherosclerotic cardiovascular risk equivalence. And therefore, what we've identified now is an unmet need whereby we can treat or prevent these patients, a majority, 2/3 of these patients, from further progressing and complicating with atherosclerotic cardiovascular disease. And this has become one of the new agendas for us in the management and treatment of type 2 diabetes. Briefly, the clinical implication of diabetes on vascular disease complications can be divided into two. As I've highlighted, the macrovascular complications, stroke, coronary heart disease, peripheral vascular disease. One can appreciate stroke increases 2 to 4-fold. Coronary artery disease responsible for 50 to 80% of diabetic-related deaths, and peripheral vascular disease, which results from atherosclerosis in the lower extremities, leading to pain and ultimately amputation. But this must not also be neglected. What we also identify are the microvascular complications. And fortunately with these, what we have learned over time from very large epidemiological studies is that with excellent HbA1c control, we're able to mitigate the progression of these microvascular complications, such as diabetic retinopathy, which ultimately leads to blindness, diabetic nephropathy, leading to end-stage renal disease, and diabetic neuropathy, leading to non-traumatic lower limb amputation. So these two go in synergy with the peripheral vascular disease. And these are the typical prototype conditions that we look out for and screen for in all our patients who present with type 2 diabetes. Now, I'm going to spend a little bit of time in the slide looking at the impact of diabetes on cardiovascular disease. And what we want to highlight here are the principles of the fact that patients who present with prior diabetes and prior myocardial infarction have the highest risk, and this is the red line graph that you see in both men and women, have the highest risk of cardiovascular mortality compared to the green line graph, where we've got patients without diabetes and no prior myocardial infarction. And one can appreciate the exponential rise and steep increase in patients with diabetes and prior myocardial infarction. So those patients in your rooms who have succumbed to atherosclerotic cardiovascular disease are at an even greater risk, and we need to treat them even more potently as compared to those without diabetes and no history of prior atherosclerotic cardiovascular disease. However, what's key is to, again, illustrate this point of type 2 diabetes achieving a coronary heart disease risk equivalent is if we look at patients who have type 2 diabetes for beyond 8 years compared to patients with prior myocardial infarction. And this is now the black line graph versus the blue line graph. These are very similar for both men and women. What one can see is that these two track each other quite well. Again, illustrating that if you're diabetic, and you've lived with type 2 diabetes for more than 8 years, you have attained the same risk of atherosclerotic cardiovascular disease and associated morbidity and mortality as someone who has succumbed from a prior event of myocardial infarction. Again, underpinning this significant unmet need and the need for us to rethink and start considering management for diabetic patients beyond glucose, because for a long time we've largely focused on glucose control and not really looking at the other elements that are important. I have already highlighted the risk factors that these patients live with. These are typically modifiable versus unmodifiable risk factors. It's the modifiable risk factors that we want to encourage our patients to work on. And these are some of the risk conditions that lend themselves suitable and appropriate to excellent medical therapy to mitigate the risk of morbidity and mortality related to atherosclerotic cardiovascular disease, such as controlling lipid management, controlling blood pressure, reducing weight, as well as ultimately controlling glucose control in these patients. What we also see is that these risk factors, when they are all in concert, what I highlighted earlier as the metabolic phenotype, they exponentially increase the risk of atherosclerotic cardiovascular disease, and hence the need to target each of these risk factors optimally in each diabetic patient, and not only to look at HbA1c as the primary target and goal. So we can see also from many epidemiological studies that living with type 2 diabetes reduces life expectancy. And if we use the age 60 as a reference point, this leads to loss of life of beyond 12 years in these patients. And this is estimated to even be greater in younger patients. Again, illustrating the need for us to treat these conditions more aggressively and more potently with evidence-based therapies that have been demonstrated to yield the desired outcome that we want. Now, as I approach the end towards setting the scene, I wanted to highlight that the issue of focusing on glucose has been there for a long time. As you can see, from the 1960s, 70s, 80s, all the way to the recent 2000s, there have been very large interventional as well as observational studies that have tried to answer the question that if I control a patient's glucose optimally, if diabetes is a glucose problem, and if I control the glucose optimally, will I reduce adverse outcomes, the macro and microvascular diseases? And some of the landmark studies, such as UK-PDS, Accord, Advance, have been reported in the past, where, again, they've demonstrated that if you look at the UK-PDS, the tight glycemic control reduces long-term complications, such as reduction in microvascular disease, reduction in amputation or death due to peripheral vascular disease, and some benefit. So definitely there is cardiovascular benefit that we see in some of these patients when we treat HbA1c well. And most of this benefit, as you can see, is by and large in terms of the microvascular disease, and some benefit that's yielded, but not statistically significant in terms of the atherosclerotic macrovascular disease. And if we look at this summary slide, where we look at the microvascular disease, the cardiovascular disease, and ultimately mortality, what we can appreciate is that intensive HbA1c control yields a desirable outcome in terms of less microvascular complication. UK-PDS, as well as the DCCT trial, demonstrated some improvement in terms of long-term outcomes with respect to cardiovascular disease, But by and large, many of these studies were neutral when it came to mortality. And again, underpinning this unmet need of treating type 2 diabetic patients beyond glucose control, we have to go beyond HbA1c. And what one can appreciate is that management of HbA1c is important for the treatment of type 2 diabetes, but it may not be enough to reduce the risk of cardiovascular events. And this then set the scene for new and novel, exciting therapies to be discovered, which needed to be tested in this unique population to demonstrate if they are able to reduce cardiovascular disease. So in my closing slide, before I hand over to Professor Fiad, who will tell you the second part of the story, is that with respect to cardiovascular disease and type 2 diabetes, this is a major cause of morbidity and mortality. And common conditions such as hypertension and dyslipidemia coexist with type 2 diabetes and are clear risk factors for atherosclerotic cardiovascular disease. These are important because they reduce life expectancy beyond 12 years for the majority of patients aged 60 years living with diabetes and having a previous cardiovascular disease. And it's estimated that this life expectancy reduction is even greater in younger patients. So there's clearly an unmet need of therapies that can improve both glycemic outcome for type 2 diabetic patients, but at the same time yield the desirable outcome of reducing the morbidity and mortality associated with macrovascular disease caused by atherosclerotic cardiovascular disease. And on that note, I'd like to say thank you, and I'd like to hand over to Professor Fiad, who will now tell us about the second part of the story. Thank you very much.
Thank you very much, Professor Betsy, and I'd like to thank the organizers for supporting this event. It's a pleasure to be with you really in this important and clinically relevant event. So in the next 35, 40 minutes or so, I'm going really to discuss the ways of preventing or ameliorating cardiovascular disease in patients with diabetes. So let me just try to get the slide on the main platform.
Should I start the presentation for you, Prof?
Yeah, please.
Okay. There you go.
Excellent. Very good. So these are my disclosures, my disclaimer, and this is the outline of my presentation this evening. So I'll start by discussing the cardiovascular disease risk in diabetes versus people without diabetes, something which Professor Betsy discussed with you. And then we'll look at the categories of cardiovascular risk in diabetes. That's very important and clinically relevant. And then I'll discuss with you really the evidence for preventing cardiovascular disease in diabetes. So I'll discuss the whole of what we learned so far from cardiovascular outcome trials. And then we'll go to the practical side of how to approach diabetic management in terms of safety of therapy, in terms of what Professor Betsy told us, thinking beyond glycemic control, so beyond this glucocentric approach, and how to individualize therapy to our patients and practice precision medicine. So the questions when to select SGLT2 inhibitors, when to select GLP-1 receptor agonists, and then go specifically to the choice of therapy in patients who are at high risk of vascular disease, but who haven't had it yet. So without established cardiovascular disease, however, they are at high risk. Before I conclude this presentation. So if we look at the cardiovascular disease and diabetes versus non-diabetics, and this is really the data from the risk factor collaboration, group. And what it showed that in men, if they develop diabetes by the age of 40, they will lose approximately 6 years of life. That's a diabetic without previous cardiovascular disease. So newly diagnosed diabetes without previous cardiovascular disease will lose, give and take, about 6 years of life. Half of it, if not slightly more, is because of vascular disease. And if we turn our attention to women, we really come up with very similar observation. Again, a woman aged 40 without vascular disease at baseline, newly diagnosed, she will lose again about 6 to 7 years of life. Most of it is because of vascular disease depicted by this red shaded area. And I think there are some learning points from this slide, because if you look at the tail end of this graph, so if you're 80 or 85, the years of life lost because of diabetes becomes absolutely minimal, absolutely minimal. And the impact of vascular disease at that time becomes absolutely minimal. And that's really because the mortality at that time would be a lot of it because of other things like accidents, like sepsis, like falls, like severe cognitive dysfunction, and all of these. So the message here is quite clear. If we are going to impact on vascular disease, we need to impact, or we need to address it when the patient is really at high risk, which is there. If we leave it until the individual becomes really elderly and frail, then it becomes really a futile exercise. That's another important really message from this data from the risk factors collaboration group. In another study, again, another elegant study, they looked at the years of life lost in people without diabetes. So, for instance, this blue line would tell us the years of life lost for somebody who sustained a previous stroke. However, if that patient with a previous stroke also had diabetic, then the years of life lost becomes really more than a decade and a half. Similarly, if you have myocardial infarction, you lose approximately 10 years of life. However, if you have diabetes as well as an MI, then you lose approximately 16, 17 years of life. So clearly, diabetes does modify the risk factor to the worse, making the point that special attention has to be given to this high-risk group of patients, i.e. people with diabetes. And if we look at women, again, we see very similar pattern in terms of the years of life lost. This is telling us, again, that women are also at equal risk of vascular disease and mortality, cardiovascular mortality, when they compare with men, making the case that even in women, if we have proven therapies to use, we need to use it really aggressively to ameliorate and reduce the vascular risk. And I'll come back to that when I talk about the trials and the inclusion of women in these trials. And if we look at the data from the major landmark studies, UK Accord study, the Advanced and Veteran Affairs Diabetes Trial, what we can see is that with all these trials, the HbA1c was brought to a magical numbers or a magical figure. So 6.4, 6.5, 6.9%, something which is very difficult to achieve in the real world. And everybody was really enthusiastic about that, predicting that achieving that A1C is going to impact on vascular disease outcomes and improve those outcomes. But surprise, surprise, that wasn't the case. So from all these trials, we can see clearly that intensive glucose lowering did not really impact vascular disease within the 5 years. If anything, in the Accord study, there was an increase in the mortality with a relative risk increase of about 21%. reasons for that were advanced, including the hypoglycemia, weight gain, speed of getting the A1C down, and probably some of the medications used. But at that point of time, we were really, and this is really before the era of the GLP receptor agonists, before the era of the SGLT2 inhibitors. So in this important example, what we see here is the glucocentric approach, and how really it failed dismally in reducing the vascular disease in patients with diabetes. So let's look at the categories of vascular risk in diabetes, because that's very important, and we need some clinical parameters that will help us to identify the risk for an individual with diabetes. In the past, we used to say that if you have diabetes and established vascular disease, you are at very high risk. But now we know that that's not the only category of the very high risk. There are a number of other categories. These categories include target organ damage. So if you have retinopathy, if you have nephropathy, that's target organ damage. If you have left ventricular hypertrophy, another example. If you have 3 or more major risk factors, vascular risk factors, and many people with diabetes will easily have the 3 risk factors, and I'll share with you an example in the next few slides. If you have a diabetes duration, a type 1 duration of more than 20 years, you are at a very high risk of developing vascular disease. And then if you look at the high risk, again, high risk of vascular disease, if you have duration diabetes of 10 years or greater, without end organ damage, but you have one additional risk factor, any one additional vascular risk factor. And the data from which was shared by Professor Zabetsi, where he showed us that when a diabetic reaches 8 to 10 years, they become a cardiovascular risk equivalent. So this is really putting that into the practice. So duration of diabetes really predict your vascular risk. And it's very important for us to ask our patient this very simple question: how long have you had diabetes for? And the reason for asking that question is to put them to categorize their vascular risk. So based on that, let's share a case history, because that will really put the theory into practice. So a 51-year-old man, diabetes duration of 9 years. So he hasn't reached 10 years, but almost there. Premature vascular disease, father had in mind at the age of 48. This patient is a smoker, has other risk factors, hypertension, dyslipidemia, obesity. So his BMI is 30, as you can see there. His A1C is uncontrolled at 9.2%. LDL is 2.6 millimole per liter. And he is taking dual therapy with metformin and gliclazide. In addition, he's on blood pressure lowering therapy with ramipril, as well as atorvastatin for his dyslipidemia. And really, we need to ask a number of important questions, such as what are this patient needs and the concerns. Obviously, the concern would be the outcomes, the vascular disease. What are his needs in terms of therapy and preventions? What factors will we use to base our decision in this patient with high cardiovascular risk? What is his vascular risk? Again, We need to know exactly, and we know from what we've seen, that he is at a very high vascular risk. Let's not forget that he has, besides diabetes, it's a duration of 9 years. He has hypertension. He's a smoker. He has dyslipidemia, and he has obesity. So really, he has a really long list of important risk factors. So the question, when it comes to his glycemic control, what therapy should we use to improve his glycemic control? And all these therapies are going to lower the A1C without any shadow of doubt. Basal insulin will lower the glucose considerably. GLP receptor agonist will do maybe something very similar to insulin, if not better, in terms of glucose lowering. SGLT2 inhibitor will be efficacious, not as efficacious as basal insulin and GLP receptor agonist when it comes to glucose lowering, or DPP4 inhibitor, agents that are free from, well tolerated, extremely well tolerated. Rarely you come across side effects. You'll get the A1C down by approximately 0.8% on average. So which one should we use out of these therapies? Or should we do nothing and keep the A1C at 9.2%? So this will take us to the totality of the evidence, and that will help us to answer the question about what's the best treatment for this patient that we have. So if you look at the DPP4 inhibitors, and I think by now we learned a lot about dipeptidyl peptidase inhibitors, sitagliptin, linagliptin, allogliptin, saxa, gliptin, and that these therapies are neutral. So cardiovascularly, they are safe, but they don't improve cardiovascular outcomes. They don't reduce vascular outcomes. And all these therapies were against control. In the Carmelina, it was against in Carolina, it was against an active comparator, and that's glamiprid. And again, in Carolina, we saw that linagliptin had similar outcome as with glamiprid, which is a sulfonyl urea. So that's really suffice to say about the knowledge that we have concerning DPP4 inhibitors. Let's look at SGLT2 inhibitors. And we learned from SGLT2 inhibitors trial that in patients with established cardiovascular disease, so the top panel from this first plot is looking at a patient with established vascular disease, and we can see that when we look at the data from 3 trials, the EMPA-REG, CANVAS, and DECLARE-TIMI, that these SGLT2 inhibitors do reduce vascular disease in patients who already had vascular disease at baseline. However, when you look at patients with risk factors but without vascular disease at baseline, we can see that these therapies are neutral. Indeed, if we add to the evidence that came from ertugliflozin, the 4th SGLT2 inhibitors, again, ertugliflozin was neutral when it came to vascular disease. The outcome with ertugliflozin, when it came to the 3-point MACE, was similar to that of DPP4 inhibitors, though a secondary endpoint suggested perhaps some benefit when it comes to heart failure. Now let's turn our attention to GLP-1 receptor agonists. And this is the data that we have so far. So with 4 of these GLP receptor agonists, liraglutide, semaglutide, albiglutide, and dulaglutide, there was significant reduction in the 3-point MACE, as you can see there. With 2 others, Alexa with lexasenatide and the weekly Bidurion, there was no benefit when it comes to reduction in vascular disease. And if you dig deeper into these trials, the LEADER and SUSTAIN 6, to learn about in the patient who benefited really when it came to reduction in vascular disease. There was an elegant analysis which was carried out, and this showed that if you had, so this is the leader trial, as you can see there, and SUSTAIN 6 with semaglutide, the weekly semaglutide. You can see that in patients with established vascular disease, liraglutide as well as semaglutide reduced the 3-point MACE significantly. And there was also a hint in the with the weekly exenatide that you have established vascular disease, there's a reduction in the vascular outcomes. However, if you look at patients with risk factors only, we can see that these therapies did not reduce vascular disease. So this is the data from the liraglutide, and this is the data from semaglutide. Another analysis which was carried out by Subbu Verma from Toronto, where again this sub-analysis from the leader study with liraglutide. So he categorized patients into those with vascular disease at baseline, the light blue, and then the dark blue are patients with vascular disease at baseline but without an MI or stroke. Let's say somebody who had a stent. And then the gray lines will be people without vascular disease at baseline. So we can see that the liraglutide reduced significantly the 3-point MACE in patients with prior MI and stroke, as well as in patients without vascular disease, but without an MI or stroke, but it was neutral when it came to patients without vascular disease. Another study by the same investigator looked at the number of the atherosclerotic vascular territories that were affected. So if you have 2 or more vascular beds, let's say coronary and vascular, so there's 2 vascular beds that are affected. If you take liraglutide, you will get a benefit. So you see a reduction compared to the control groups at red. If you have vascular disease in 1 bed, like let's say peripheral vascular disease, for argument's sake, without a minor stroke, but you have peripheral vascular disease, then you will get a benefit from liraglutide. However, if you have no vascular disease at all, so 0 vascular bed, liraglutide did not reduce the risk of future vascular events. So again, the data is consistent from this analysis as well as the previous analysis that I shared with you. And this takes us to another study called the REWIND with liraglutide. This study looked at again, the outcome was the 3-point MACE, non-fatal MI, non-fatal stroke, cardiovascular death. They included patients with type 2 diabetes. A1C does not exceed 9.5% at baseline. So many patients, as you see later, they will have A1C actually less than 7 and less than 6.6 at baseline. And let's see if the medication really, if those with a low A1C at baseline, they could benefit really from this treatment. They need to have a GFR of more than 15 to be included in this trial. So they randomize them in 1-to-1 fashion to either liraglutide 1.5 milligram once a week, so the dose is 1.5, or control plus standard of care therapy. So in what way is this trial, in what way does it stand out compared to others? And here we're looking at the annual MACE rate by trial. So all the other trials included patients with a very high risk. So we can see that the annual MACE rate is high, 5.9, 4.4, liraglutide 3.9. But when it comes to the REWIND with liraglutide, it was a much lower risk, only 2.7% per year. So that's really one of the major distinctions of the REWIND from the rest of the trial. It included patients with lower cardiovascular risk at baseline. But also, it included women who were well represented in this trial, 46% of women. And we talked about the fact that women, they lose the cardiovascular protection if they develop diabetes. And we need to know, does this therapy help them, the women as well as men, or not? And if you compare the proportion of women in the rewind to the other trials, you can see that with other trials, the proportion was about a third. In this trial, it approaches 50% or so. The other trials, as I pointed out, include patients at very high risk, some of them 100% with a vascular risk, like, for instance, the Harmony outcome. But with rewind, less than a third had vascular disease at baseline. So we're talking about just more than 2/3 who had only vascular risk factors. Mean A1C was 7.3%. So the trial was designed to test not only the high A1C, but also those at the lower end of the spectrum. And the median follow-up was by far the longest compared with other trials, 5.4 years. So now let's look at the primary outcome. And we can see that with dulaglutide, there was significant reduction in the 3-point MACE when compared to the control groups, 12% relative risk reduction, and this is the P value. And we can see that the Kaplan-Meier curve started to diverge at approximately 6 to 9 months, and it carried on diverging afterwards. And if we look at the components of the 3-point MACE, so they all moved at the right direction. So we can see 9% relative risk reduction in cardiovascular death, 4% for non-fatal MI, 24% in non-fatal stroke, and the all-cause mortality 10%. If we look at is there any heterogeneity in the response to the dulaglutide? You can see very clearly that older as well as younger patients, they responded in a similar manner. Men and women responded in a similar manner, so there was no heterogeneity in the response, indicating that women had similar benefit as with men. And again, the benefit was seen regardless of the duration of diabetes. If you have an A1C, which is reasonably good at baseline, less than 7.2%, you will still get the benefit when it comes to reduction in vascular disease. And this really impacted on the guidelines, as I will discuss later, because the guidelines now will say, regardless of the A1C. That's the key point from the guidelines. So a patient with higher A1C and lower A1C had similar benefits. And finally, as I said, this trial included patients with a very high risk, and sub-analysis from other trials suggested that there was no response when we looked at the subgroup of the leader trial with dulaglutide and the SUSTAIN-6 with semaglutide. But here we can see very clearly that the high-risk patients with risk factors, they had similar benefit as with those with established vascular disease. So both groups, whether you have risk factors or you have established vascular disease, you will have benefit from the treatment. And if you look at the trials really and how many and the kind of patient that we see in our clinic, the patients who are recruited to the leader and SUSTAIN-6 represent perhaps only 12 to 13% of the clinic attendees in a routine diabetes clinic. But the patients included in the rewind trial really represent approximately 43% of the clinic attendees at a routine diabetes clinic. So 2.5-fold more patients with the rewind compared to the SUSTAIN-6 and the leader. So we'll go to the next part of the practical side of the presentation now, is how to approach diabetes management. What's important for us as practitioners? Obviously, one of the things which is important is to achieve glycemic goals safely. And with this regard, the 2022 ADA guidelines will say that safety implies minimize the risk of hypoglycemia. So when it comes to minimizing the risk of hypoglycemia, you have four choices. You have the two incretin-based therapies, DPP-4 inhibitors, GLP receptor agonists, as well as SGLT2 inhibitors and thiazolidinediones. But then if you want to also avoid weight gain, and if you want really to help the patient to lose weight, then you have GLP receptor agonists, more efficacious, followed by SGLT2 inhibitors. So this is really approaching the treatment in a safe manner. But that's really not enough. So yes, we need to get things done in a safe manner, but we also need to think beyond glycemic control, because beyond the glycemic control implying that we need to improve the vascular outcomes for our patients. Because as you recall in the initial part of my presentation, we talked about the studies that are called VADT and advanced, where they got the A1C to a lower level, but it did not impact on the macrovascular disease. It did impact on the small vessel disease, microvascular, but not macrovascular disease. So with macrovascular, we need really to explore things beyond the A1C and beyond the glucocentric approach. So the question then is when to choose SGLT2 inhibitors. And the guidelines are quite clear there. So to a patient with or without cardiovascular disease, to reduce the risk of heart failure or chronic kidney disease progression, the strongest evidence support the use of SGLT2 inhibitors. And this is the joint statement. And the question then is when to use GLP-1 receptor agonists. So the consensus, again, the consensus statement state very clearly that in patients who already have vascular disease at baseline, where atherosclerosis is the gravest threat, GLP receptor agonists really have the strongest evidence for use in these patients with established vascular disease. The joint statement will come up with the similar conclusion. So the strongest evidence is in favor of GLP-1 receptor agonists. How about the ADA guidelines 2022? Again, in patients with established vascular disease, you have the GLP receptor agonists as a therapy with proven benefit in these patients. And if you need additional therapy, you have SGLT2 inhibitors, again, which in patients with established vascular disease showed benefit. How about the patients who are at high risk, but without established vascular disease at baseline? So you recall I shared with you the very high risk, a patient with diabetes and 3 risk factors, a patient with diabetes and the end-organ damage like urea or GFR less than 60, or retinopathy or left ventricular hypertrophy. These are all patients with a very high risk. A duration of diabetes of more than 10 years is a high-risk patient. So what are the choices of therapy in these patients? Because many trials showed that agents had no impact on reducing vascular disease in these patients. So this will take us to this question. As per the consensus guidelines, the level of evidence to support the use of GLP-1 receptor agonists for primary prevention is strongest for dulaglutide, but lacking for other GLP-1 receptor agonists. Is this statement true or false? So let's look at the high-risk patients. The high-risk patients, the recommendations is to use GLP receptor agonists, which is supported by the evidence, and regardless of the baseline A1C. And that's because the REWIND trial, which I showed you, showed a benefit in patients with lower A1C as well as patients with higher A1C. So a patient with a median A1C below 7.2%, they had similar benefit to patients with higher A1C. And because of this, the guidelines will say that regardless or independent of the baseline A1C, use this therapy. And if we go to the REWIND trial, we can see that a quarter of patients had an A1C of less than 6.6%. Did they benefit from dulaglutide? The answer was yes, they did benefit. Similar benefit to those with higher A1C. So this is really the analysis which I showed you earlier, that the benefit was similar regardless of your baseline A1C. And it's regardless of whether you had a vascular disease at baseline or not. And the joint statement will come to the high-risk patients, and it will state very clearly that the level of evidence when it comes to the use of GLP-1 receptor agonists for the primary prevention is strongest for dulaglutide, but lacking for other GLP-1 receptor agonists. And some of these high-risk patients included, as I said, patients with LVH, albuminuria, GFR less than 60, 3 major risk factors, longer duration of diabetes, and so on. So compared, if we put all these trials together as GLP-2 inhibitors and GLP-1 receptor agonists, the green column of the green colored columns, they represent patients with high risk but without vascular disease at baseline. And the red represent patients with established vascular disease at baseline. So you can see very clearly that for most of the trials, if you have established vascular disease at baseline, you see a reduction in the 3-point MACE. So here you can see reduction, and then you see with leader, sustain 6, harmony outcome, and with REWIND. But now, let's look at those without vascular disease at baseline. The green column, the green color, the green shaded columns. In the canvas, no benefit from canagliflozin. In the declared TIMI, no benefit from the pagliflozin. No benefit from liraglutide in the leader. No benefit from semaglutide in sustain 6. But in the REWIND, there was a benefit, as I showed you earlier. So this is the first trial really to show benefit in the setting of primary prevention. And as I said, the patients, the routine attendees of the clinic, we can see that a significant proportion will meet the criteria of the REWIND trial when you compare it to the patients who are recruited for the sustain 6 and the leader trial. A food for thought is, although the guidelines are quite clear that in patients with vascular disease, you need to use therapies with proven evidence. Still, and this is the ASD presentation, we can see that only 20% of patients with established vascular disease are taking therapies which will help to improve their vascular outcomes. So really, this is something that we need to stop at and think and reflect in our practice, that we are not prescribing therapies which are associated with vascular benefit. 1 in 5 patients are receiving this therapy. We see that we give the therapy and a similar proportion of people with vascular disease as well as with those without vascular disease. Again, suggesting that we're not making the distinction in the routine clinics between the high-risk patients and the low-risk patients when we're prescribing these therapies. So that's really, again, another point to reflect upon. So back to our patients. Back to our patients, and this is the slide before last. We need to reduce his A1C, no doubt. Less than 7% and ideally less than 6.5%. We need to reduce his risk of vascular disease, and we need to think beyond A1C. So he's a high-risk patient without established vascular disease, and the benefit really the evidence suggesting that in these patients like this, it would be GLP receptor agonist such as dulaglutide, which has the strongest evidence for primary prevention. We need to give the therapy safely, so we need to avoid hypoglycemia. His LDL is not controlled, it's 2.1. And so he really is far away from the goal. He's taking it over 20, so we need to bring him to less than 1.4 by maximizing the statin intensity, by adding ezetimibe, and if the need arises, by adding PCSK9 inhibitor. We need to get his blood pressure to goal, extremely important, and obviously we need to help him to reduce weight. So to conclude, ladies and gentlemen, patients with diabetes have high cardiovascular risk, as I shared with you earlier, as well as Professor Cepetsi. Options of therapy are individualized and should be tailored to the individual patient's profile. We need to start to think beyond the glucocentric approach, and we need to think about how to improve the outcomes for our patients in terms of reducing vascular disease, in terms of reducing heart failure, in terms of kidney function protection, and so on and so forth. Some GLP-1 receptor agonists demonstrated MACE reduction. At most, this was only evident in patients with established cardiovascular disease. By comparison, in dulaglutide-treated patients, the reduction in cardiovascular events was observed in a wider range of patients with diabetes, regardless of the gender, regardless of the baseline cardiovascular disease status, regardless of the age, and regardless of the A1C level, lower or higher. Similar benefits were observed in the Rewind trial in patients with prior and with no prior vascular disease, in men and women, in patients with higher and lower BMI, and in patients with higher as well as lower A1C. And with that, I conclude my presentation. Thank you for your attention. I'll be happy to answer any questions.
Thanks, Prof. I see we are going over time now. Would it be okay with both of you if we just add another 10, 15 minutes to answer some questions?
Yes, it should be fine, Conrad, on my side.
Okay. Here's a question here. With elderly patients well controlled glucose on insulin, what's the risk of hypoglycemia when a GLP-1RA is added to their therapy if you are trying to address their CV risk? And how would one typically introduce the GLP-1RA in such patients?
Okay, let me take that. I think this is the obese question. So the question is, the patient is taking insulin, isn't it?
Yes. Yeah, elderly patients with well-controlled glucose on insulin. Okay. What's the risk of hypoglycemia? Yeah.
So I think if we go a step backward, and the guidelines are very clear nowadays to say that when you're considering injectable, the first injectable should be a GLP-1 receptor agonist rather than insulin. Because a number of things, because the efficacy, and we saw the data again from the award trials, dulaglutide against glargine. So we saw the benefits with dulaglutide. So the efficacy is slightly probably similar or slightly better for GLP-1 receptor agonists when it comes to efficacy compared to basal insulin. And then, obviously, there's a big difference in the risk of hypoglycemia. So GLP-1 receptor agonists not associated with hypoglycemia, insulin does. And then with the weight, so with GLP-1 receptor agonists, there's weight loss, insulin, there's a weight gain. But having said that, this question is a bit different. The patient is already taking insulin. So patients are already taking insulin, and they're well controlled. So we need obviously to start by weaning off the insulin. So for somebody who is at high risk of hypoglycemia, and they're well controlled, by the way, because that's what the question says, I probably cut down the insulin by at least 50% at the point of introducing the GLP-1 receptor agonist, making sure that the patient is monitoring frequently and be given advice about if his or her glucose. I'll cut the bolus more than the basal to start with. If they are taking basal only, obviously I cut it down by at least 50%, and educate them obviously about the risk of hypoglycemia. And you will find that this is a very relevant question, because sometimes you come across these patients, and sometimes the outcome is very rewarding, because you will find that with some of these, you find that at the end of the day, you stop the insulin altogether, and they are well controlled with the other therapies, weekly GLP receptor agonist with probably metformin and SGLT inhibitors.
Okay, excellent. Thank you. There's another question. Should all newly diagnosed type IIDMs be commenced on lipid-lowering agents on diagnosis?
All right. Okay.
Take it first.
I can give an approach to that. So generally what's happening now with many of the cardiovascular diseases, including diabetes, hypertension, as well as dyslipidemia, is that we realize that many of these conditions are conditions where patients are asymptomatic and have not yet succumbed with either an atherosclerotic event or any condition that leads to symptoms. And so what we generally do, we have tools that help us to risk stratify patients in terms of determine their cardiovascular risk. There are many that are available in our diabetic patient, if not all, will have a high cardiovascular risk. If you just assess they've got type 2 diabetes, they probably are hypertensive, they've got central obesity, they've got asymptomatic organ damage, whatever the HbA1c is. And there are also unique tools for assessing cardiovascular risk in diabetic patients now as a subpopulation. So using those tools, one is easily able to ascertain whether this is a very high-risk patient, high-risk patient. And in most type 2 diabetic patients who are high-risk or very high-risk patients, they would need a targeted LDL cholesterol. So we now treat LDL to target. We don't just give statins or add ezetimibe willy-wally. We now use targets depending on the cardiovascular risk. And in that setting, if the patient has a high cardiovascular risk, of which the majority will, especially type 2 diabetic patients, because as I said, they generally have metabolic phenotype as a precursor before they actually now are diagnosed to have diabetes. And you'll usually find they have habits. Because as clinicians, if you adopt this habit of when I see my patients, immediately first is a risk stratify. And if you risk stratify, it becomes very clear what is my treatment target, both for hypertension, both for the dyslipidemia, in order to reduce the atherosclerotic cardiovascular risk. And I hope that's a more of an approach response rather than just a simple yes or no answer that I've given the person who's asked that question. Thank you. Prof Fiad, if you want to add, you may go ahead as well. Thank you.
Thank you very much. Yes, I concur really with it's not a matter of only statin, but as you pointed out very clearly, get to the goal. And I think this is again where I think for instance the Vinci analysis in Europe and not only in Europe, but I think across the world, is showing that clinicians, they are prescribing the statin therapy by habit, so moderate dose, moderate intensity statin, a dose of 20, and then they leave it for years and years. So they don't go to target. And as Professor Betsy pointed out very clearly, we need to drive to target. And the European Society of Cardiology would say, for instance, in the very highest patients, like for instance, the one I shared with you, or somebody who had a previous event, you need to go to a less than 1.4, but not only less than 1.4 or 55 milligram per deciliter of LDL cholesterol, but you also need to reduce the LDL by at least 50% from baseline. So somebody who has a baseline of 2.2, you need to get their LDL to 1.1. That's 50%. And to achieve that, we need really, most of the time, combination therapies to get to goal. And getting the LDL to goal is extremely important in reducing vascular disease in patients. Thank you.
Thanks to both of you. Just two more questions. Is there an interaction between these two conditions and depression? I'm not sure which two conditions he's referring to. Yeah.
If they're referring to diabetes, yes, diabetes is well known to be associated with depression. We know that there's a lot of demand for people with diabetes, particularly type 1 diabetes, where it's really 24 hours a day, 7 days a week of jobs. They have to think about the diet, they have to think about the exercise, they have to think about testing. Important with these patients.
Thank you. And the final question is a comment. I suppose either of you can comment on it. A comment on extended 2.5 years of life on the EMPA-REG study or EMPA-REG study.
EMPA-REG study is the cardiovascular outcome trial with empagliflozin. So it included, it recruited patients. All patients had vascular disease at baseline, and the outcome from that trial was a reduction in the 3-point MACE, so they were significant. There was a reduction in vascular death, and then a sub-analysis, which was confirmed later by other studies like the EMPA reduced and the EMPA preserved, there was a reduction in heart failure.
Yeah, just if I can add on there as well, Conrad, just to highlight. So EMPA-REG is looking at the SGLT2. So it's another molecule, one of the new innovations that treat both diabetes but have cardiovascular benefit. And as Prof Fiad has illustrated, all these studies were looking at cardiovascular outcomes in terms of safety for these new therapies for diabetes. And just like the dulaglutide in the REWIND study, which demonstrated benefit, and what's unique in the REWIND is that and with dulaglutide is that a majority of these patients cardiovascular events, it's the one SGLT2 of those that are available that has demonstrated a mortality benefit in patients with atherosclerosis, and generally as a class, the SGLT2 seems to have benefit in heart failure reduction, and now even as heart failure therapy, even in patients without type 2 diabetes. But also another exciting study or outcome highlighting these advances in therapies for patients with type 2 diabetes, and underpinning again this unmet need of addressing atherosclerotic cardiovascular disease as a new target and a new outcome measure to look in these patients.
Excellent. Well, thank you. Thank you so much to both of you. Excellent presentations, and thank you for staying to answer some questions for us. Thank you everyone for joining us tonight. Thank you to Prof Fiad and Prof Tabete for great presentations. Just a reminder that thank you to Eli Lilly, first of all, for sponsoring this event. If you would like to be contacted by Eli Lilly after the event, please remember to type Y in the chat section. The chat section should still be